Broadcast is now starting. All attendees are in listen-only mode.
Good evening, and thank you for joining the RLS Foundation's webinar titled Ask Dr. B. My name is Carla Diezenkowski, and I'm the Executive Director at the RLS Foundation. Tonight, we are trying a new format for us. Rather than the 30 minutes on a specific topic and 30 minutes for questions, the entire hour will be devoted to answering your questions. Our audience will remain on mute during this hour, and we will begin with questions submitted upon registration. However, if you have questions during the hour, you may submit them in your console below chat, and I will pose those questions to Dr. B as time permits. Please keep your questions general so that the entire audience will benefit. Dr. Buckfuhrer cannot recommend specific medications, dosages, provide a diagnosis, as that requires a face-to-face medical appointment with a healthcare provider. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in our member portal section of our website. If you're not a Foundation member and you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. Mark Buckfuhrer. He is a consulting assistant professor at the Stanford School of Medicine. He sees patients and teaches sleep medicine to doctors training at Stanford RLS Clinic. He is a member of the RLS Foundation's Quality Care Center Network. He is board certified in sleep medicine, pulmonary disease, and internal medicine. Dr. Buckfuhrer, we thank you for sharing your time and expertise with us today. We received many great questions already, so let's get started.
Okay, thank you very much.
Okay, first question, does RLS ever get better or just go away?
Well, for the most part, the majority of the people will have their RLS stay about the same by the time they hit 50 or 60. It may get a little worse after that over time, but hopefully not terrifically worse unless we do things to make it get worse, like medications, stress, anxiety, low iron, a whole bunch of stuff. But assuming that nothing else unusual happens, it typically just gets slowly a little worse over decades or stays about the same. However, there's a small percentage of patients, and there's been some studies on this and may vary from 15, 20, 30+%, that may have a spontaneous remission. It just goes away. How or why this occurs, we're not sure. Maybe patients get a little more iron in their diet or otherwise, but it's not been looked into that well. But some patients just all of a sudden notice, hey, I don't have my RLS, it's gone away. Maybe they've never even taken medication, or maybe they stopped their medication. But for the most part, the majority of the people can assume that once you have it, it'll usually stay about the same, unless you're in the minority that may have it go away permanently or temporarily.
How common is it for RLS patients to experience periods of times with no symptoms, or do symptoms just increase in frequency with time?
Okay, this is kind of similar to the previous question, but a little different. Patients with mild RLS may have it intermittently, so it may go away and come back depending on, again, stress levels, other issues with pain that may aggravate restless legs, medications, etc. But the patients who have moderate or especially severe restless legs usually have it every single day and do not have much of a break unless they get good medication. And just like I've answered in the previous question, typically the symptoms may get a little worse with time, both in intensity and in frequency. But most of the patients will notice this occurring very slowly over a decade or two or more.
I have RLS/neuropathy and want to know if there is any correlation between fluoroquinolones and magnesium deficiency.
Okay, to the best of our knowledge, there's really no correlation with restless legs and the fluoroquinolones, which are drugs like Cipro or Levaquin, which are commonly used drugs. And again, and magnesium deficiency once was thought to have a correlation with restless legs, but really doesn't. And as far as neuropathy, neuropathy tends to be somewhat more common in restless leg patients. We're not sure why. Again, this is a kind of a weak correlation that we don't know if it's cause or effect or just common in, people of a certain age that may be more prone to get both of these conditions.
One of the questions we just had submitted is, what is the relationship between nocturnal micturition, not infection related, and RLS?
Sorry, can you repeat the question?
What is the relationship between nocturnal micturition, not infection related, and RLS?
Okay. What the question means is nocturnal micturition is people who have this bedwetting at nighttime, which is obviously more common in kids, tends to be less common in adults because it occurs in very deep sleep. And there's really no relationship whatsoever with restless legs.
Is there any connection between lack of calcium and RLS?
To the best of our knowledge, there is no relationship. We've looked at almost all the mineral, vitamins, and all kinds of other stuff, and have not really found any relationship except for the relationship which most people will probably know between restless legs and low iron levels.
Another question we just had submitted is RLS associated with being overweight?
As far as we know, I don't think there's any correlation with being overweight. I know this has been looked at, and I frankly can't remember exactly, but I think there's no specific correlation with that.
Okay. What are your thoughts on low vitamin B link and RLS?
As I said before, I think all the vitamins really have no association with restless legs. The only kind of mineral is iron, of course, but barring that, really all the other vitamins really don't have any association or interaction with restless legs.
Okay, another question we just had submitted is, why would symptoms be worse during menstrual cycles?
We think that that's mostly hormonal, and there's some interesting new work on hormones and restless legs. We've always known that there's a much higher percentage of restless legs in pregnant women, especially in the second and third trimester. And one of the researchers from Switzerland, Mauro Manconi, did a very nice study where he was looking at the estrogen, progesterone changes during pregnancy. And what he found is that many women all of a sudden have an improvement in their restless legs a few days before they're going to deliver. And in fact, he said in the study he did, he could tell the patients when they came in and said, "Oh, my RLS is better. You're going to deliver in about 2, 3, 4 days." And what he found was that's when there was a big change in the hormones of estrogen and progesterone, and that kind of ended the increased restless legs that these patients had, and also was a precursor to delivery. So we know that female hormones could make a big difference. The kind of PMS period that women get when they're having menstrual cycles correlates very strongly with more heightened restless leg symptoms. And I've seen many patients who, especially in the old days when we used to give more hormonal therapy for postmenopausal women, would get better or worse when going on or off hormonal therapy. So there is a link, and it probably has to do with the female hormones.
What has research been carried out on the effects of supplemented oxygen and RLS?
To the best of my knowledge, no, and I'm also a lung specialist. So I've had patients who are on oxygen and have restless legs, and I've never heard anyone comment that if they don't use their oxygen, their restless legs get worse. So I'd have to say, even though there's a lack of any research on this, just from my own personal experience, I'd say I doubt there's any correlation here.
Okay. Can low copper, B12, or a continent ileostomy cause restless leg syndrome? Does improved nutrition help with RLS?
For all of those, the answer is really there's no association with any of these things and restless legs. Nutrition, there are patients who really think that certain products such as refined carbohydrates or gluten, sugar, when taken may worsen their restless legs. But from my survey of patients, personally asking patients and speaking to patients at support groups, I've really found there's no great correlation, and this is more anecdotal on an individual basis. So it's really hard to say whether nutrition is important. The only thing I could say is if patients ate a lot more red meat and liver that has a lot of iron, that might help their restless legs because it does improve iron levels. But of course, we don't want to encourage our patients to also raise their cholesterol and other issues associated with that type of diet.
I've another question we just had submitted. I think that I have RLS, but how do I or my doctor confirm that I have it? Is a sleep study necessary?
Okay, well, I'm a sleep specialist, and I both read and order a lot of sleep studies. And I will tell you, you do not need a sleep study to diagnose restless legs. The only exception for this is in young children who obviously will have difficulties in articulating their symptoms. So if you have a young child that you think might have probable restless legs, doing a sleep study and finding associated periodic limb movements, the PLMs, might help push you a little bit to the diagnosis. But in adults, it should be done, the diagnosis should be made completely on the diagnostic criteria and making sure you rule out any things that mimic restless legs. And if done appropriately, that's all you need. A sleep study would add virtually nothing to help diagnose these patients.
All right, an iron question. Do you recommend continuing ferrous sulfate to maintain a level of approximately 100 micrograms per liter?
Well, let me take the 100 micrograms per deciliter first. As far as what the right level is, we're not really sure. The latest and best study we have shows that if you get the ferritin levels above 50 to 75, then patients do better. But in my own personal experience, where we give iron infusion therapy, we get the levels up usually in the 2 to 300 range, we see much more profound effects. And then what's interesting is I've had a whole bunch of these patients who, when they get down to even levels higher than 100, I have one patient who, when she hits 130, she starts complaining about restless. Actually, what happens? She complains about restless leg symptoms. We then do a spot check on her ferritin levels, and they could be as high as 130 or 140, and then she'll respond to an infusion. So what that number really is probably varies from person to person, and we don't know it that well yet because that's only the measure of iron stores in the blood. The real number would be, the important number would be how much gets in the brain, and of course we don't want to do spinal taps on everyone to figure that out, but everyone probably needs a different level of iron in their blood to get a reasonable level in their brain. But the other question about how long should you continue the iron, once I give a patient an iron infusion or get their level to a point where they're doing pretty well, I usually have them continue 1 iron tablet per day, because we know that patients who respond to iron therapy tend to lose iron much more quickly than normal people, like up to 10 times more quickly per day, and we don't know where, how, or why. So continuing to take iron once you've taken it for a while and done better with it is likely a very good idea so that your levels don't drop down. But I don't have a good target number. I would just say continue to take it, and if you're not doing well, they can check ferritin levels and see if they have to boost it in other fashions.
Another question on iron is, at what point as a provider do you determine that a physician, individual with RLS is taking iron supplementation and that it's doesn't seem to be working out, and then you would offer IV iron as an option?
Okay, this is a question that comes up all the time when we're treating patients. The issue we have is when you have a very low ferritin, most labs will say a normal ferritin is above 10, 20, or sometimes 30. But as I just mentioned with the other question, we like to get it at least above 50 to 75. So if you see a patient that has an iron level, or sorry, a ferritin level of about 5 or 10, they will absorb 20 or 30% of the oral iron that we give them. However, once the ferritin level gets up closer to 50, they may absorb 2% or less of the iron. So it's sometimes very difficult to get the iron or ferritin levels high enough. The other issue you have, many patients get constipation or stomach upset and can't take enough iron to get their levels up. So this is something that occurs quite a bit. And I would have to say that actually there is only a minority of patients who can take enough oral iron to get their restless leg symptoms improved. So what happens is if I have patients who have iron levels, or sorry, ferritin levels below 50, and they're not doing well, and we may have to increase medication or add another class of medication, I will usually offer them an iron infusion as a alternate therapy instead of additional or different medication.
Is there a safe amount of iron that a person should take each day if you have severe RLS?
Okay, there's some new data on how much iron you should take. Up till about a couple of years ago, we always thought that if a little iron is good orally, then more iron has to be better. And then we found out some interesting stuff based on some studies done at Johns Hopkins. What they found was that as you take more oral iron, your body produces something called hepcidin, which then decreases the absorption of that iron. So the optimal amount of iron, instead of the old 3 per day on an empty stomach, 1 tablet 3 times a day on an empty stomach with vitamin C, we now recommend only 1 iron tablet, typically 65 milligrams of elemental iron. If you look at the whole compound, it'll be 325 milligrams of the ferrous sulfate compound once a day on an empty stomach with something that acidifies the stomach, such as vitamin C or perhaps acidic orange juice.
Are there any recommended levels of iron, meaning ferritin, for children?
You know, the children haven't been studied quite as well, but we really kind of use similar numbers for the kids, and kids need, a significant amount of iron. Also, they're growing, so it's probably very safe to use the adult recommendations for the kids.
And Kristen, if you would contact us at info@rls.org, we can get you the children's brochure that has more information specific to kids, and we have 2 other a complement of materials that we can send to you. As you know, I'm a mom with a child who has RLS. All right. Regarding IV iron infusions for RLS developed at Hopkins, are there any clinics in California or Western US for this treatment?
Well, the first part of that is, or the part about clinics in California is simple. Since I'm in California, either at Stanford, we have an infusion center, or I have a private office in Southern California where we arrange for this all the time. but you don't really need a clinic. All you need is a doctor who will write a prescription for you or arrange to have an infusion. And these infusions can be done as an outpatient in any hospital that has an infusion center. But in addition, most hematologist oncologists, the cancer specialists, they give iron all the time. So what I've done in my local practice in Southern California is I have a few uh, hematologists, oncologists who give iron in their office, and I've kind of arranged for them that I could send my patients there, and they just do it in the office, which of course is less expensive than an infusion center, and it's it's a little easier to schedule and less fuss and muss. The only issue with that is we have only certain intravenous iron therapies that we like. Not every intravenous iron preparation works as well. So we have a couple of protocols, and what I usually do is I'll fax, email, or whatever, one of my protocols to the hematologist, and hope they follow it. I have to admit that sometimes we have to call them a few times because they typically are used to doing it a little differently than we do it. And as you know, doctors kind of like to do what they're used to doing. So we sometimes have to cajole them and tell them, hey, please follow our protocol.
Mm-hmm. What recommendations do you have for lifestyle changes and work accommodations to handle RLS?
Well, this is a very common thing that comes up. Not too long ago, I had a patient of mine who was a floor supervisor and had to walk around and make sure everyone was doing their jobs, and really enjoyed his job, and was doing it so well that the higher up said, "Yep, we're going to promote you," and he got a desk job. And his RLS went from incredibly well controlled to horrible because he had to sit at the desk all day. And in fact, I offered him, additional medication or a few other tricks, which I'll talk about in a second. And he just said, nope, I love my other job. I'm going back to be floor supervisor, and I don't care if I'm losing money. I do much better moving around and I like moving around, and it takes care of my RLS. But what can you do if your job has no option? Well, we have a few choices. I have many of my patients who have purchased or got their companies to purchase for them a standing desk, and that enables them to stand and maybe move around a little bit while they're working, and will often take care of restless legs, even though they may be working at a computer station or writing or whatever. And these you can put to different heights. You can sit down for a while, stand up. So, and they're not too expensive. Now, a few of the things I've seen, but only on TV programs where they show some very high up executives, is a treadmill desk, where there's actually a treadmill built under the desk. And of course, these are for executives who want to get their exercise, not to treat their restless legs. But when I saw that, I said, boy, that would be really nice for a restless leg patient. But I think that you couldn't walk obviously all day, but you could do it for a little bit. But I think those are very expensive, so I'm not sure too many companies would spring for them. Okay.
What is a good way to approach a neurologist about you haven't seen before about your RLS symptoms without sounding like you're crazy?
Well, I'll tell you, if you have to worry about your neurologist looking at you like you're crazy, you might be going to the wrong neurologist. And what I would always say before, if you haven't seen the neurologist, what I always recommend my patients to do, or if they're going somewhere else, or if I get calls, usually patients' family, friends, or whatever, from other areas, I say call up the neurologist office and speak to the office manager or nurse that's there, and just say, hey, how many restless leg patients do they see? Are you comfortable with it? What do you prescribe? And they'll usually tell you pretty quickly, yeah, we see them all the time, and we prescribe a lot of different drugs, or we hardly see them, and we think they're drug seeking patients, so we don't like to see them. that, make sure that you may want to do a little homework before seeing the doctor to make sure that that's not an issue. Because if you see a neurologist and he gives you that look, then you clearly are in the wrong place. And I think there's nothing you can do to make him understand what about RLS and what he should be doing.
How does a horizon function in terms of pathophysiology of the RLS patient?
Well, for the first part, let me just say that we don't fully understand the pathophysiology of restless legs. So how any of the drugs truly work still remains a mystery. And I'm including all the dopamine drugs, all the Horizon class drugs, which include gabapentin and Lyrica, and all the opioids. So we don't quite understand that. We just know that they do work. Horizon, Lyrica, and gabapentin work on something called the alpha-2 delta area in the brain, and I won't go into that because it's pretty complex, but how and why that helps RLS, we're not sure. But there's one other interesting phenomena that is very unique to these alpha-2 delta drugs, which include Horizon, gabapentin, and Lyrica. The group at Hopkins have found that many RLS patients have what we call hyperarousal, which is kind of bad at bedtime because it'll cause insomnia. But given the amount of insomnia that RLS patients have, they are less drowsy the next day, which is a good thing. And that's how this was initially found. Now, what they thought the problem was, what they correlated with this hyperarousal issue is high glutamate levels. And what we know is the Horizon group of medications lower glutamate, which is probably why sedation is the most common side effect from those drugs. Now, if the sedation occurs, if it's timed right and it just occurs at bedtime and sleep period, then that's obviously a positive thing for RLS patients who have both RLS and some insomnia problems. And again, when I see a patient who has both insomnia and restless legs, obviously the Horizon class of drug would be a very, very good choice.
I've had RLS for over 30 years. I take Norco 10, 325s and Dilaudid. I'm concerned about side effects. Are there any other meds that can help?
Okay, the first thing I would say is, if this person has been using Norco or Dilaudid, typically it's because other drugs didn't work, or perhaps this person just got on those drugs and they worked, so they stayed on them. As far as the Norco goes, you can see there's two numbers there. There's the 10, which represents 10 milligrams of hydrocodone, and the 325, which is 325 milligrams of acetaminophen or Tylenol. Now, the Tylenol portion of Norco does not help restless legs. So if someone's taking that on a daily basis for years, they're taking a drug that has no benefit but could have a small but significant risk for liver or kidney trouble. So I will never give a drug like Norco on a regular basis for restless legs, unless, of course, you're treating an orthopedic problem simultaneously. The Dilaudid, which is hydromorphone, is a pure opioid. There's no acetaminophen or ibuprofen, which are often combined with the Norco class of drugs. So that drug, since it's pure, the only risk you're getting is from the opioid. And typically, if you're going to have problems with the opioid, they'll appear within the first few weeks or months at the most. Once you get through that period, there's probably no real significant long-term issues as long as the dose is kept low, so you're not worried, of course, about tolerance dependence or possible addiction. But barring those things, which should be, if they're monitored correctly, shouldn't be an issue, there's really no long-term side effect concerns about those. So I wouldn't worry that much about it. However, the opioids are drugs that we use for restless legs typically when the other drugs shouldn't be used or failed or have caused side effects. So what I would say to this person, if they've never tried anything else, the drug that I would recommend is one of the alpha-2 delta ligand drugs, which, as I mentioned just earlier, are Horizont, gabapentin, or Lyrica.
I take 1 milligram of pramipexole and still get restless legs and arm shakes. Would changing medication help, or a higher dosage of the same?
Okay, so this is a situation that I see extremely often in my office and up at Stanford. The maximum dose recommended per day for restless legs of pramipexole, which is Mirapex, is half a milligram, 0.5 milligram, or half the dose that this person is taking and still having trouble. Now, and let me just say that myself and a very small amount of the other experts, because there is a lot of controversy over this, suggest that the highest dose that, at least that I recommend, is 0.25 or a quarter of a milligram per day, because the lower the dose, the less chance of augmentation and problems. Now, when someone gets up to a milligram of pramipexole, the reason why they're on that high a dose is because they've almost assuredly developed this augmentation or a worsening of restless legs from being on this dopamine agonist drug. And what the augmentation is, I'm sure most of you know this, but I'll just mention it briefly. Augmentation occurs primarily with the dopamine, especially a short-acting dopamine agonist drugs like pramipexole or Mirapex and Requip or ropinirole. Initially, these drugs may help, and they may help for months, years, etc. But sooner or later, a very high percentage of the patients will get a worsening. And what most doctors do is they say, well, the disease looks like it's getting a little worse over time, and they give more. And that makes the patient better, again, for months or years, but they keep needing more and more because the more you give these drugs, the more you drive the augmentation problem. So when I see a patient on a milligram of Mirapex or pramipexole, and they're still doing badly, I know they're in the middle of a augmentation issue. If I give a higher dose, they will be happy for a while, but they'll come back and be worse and worse. And I sometimes see patients who are on 2, 3, 4, 5, or even 6 milligrams doing horribly. So I like to keep the dose as low as possible. And what I would do in this circumstance, and this is very well explained in the augmentation paper that a bunch of us wrote, that is also available as a free download from the internet. We usually recommend changing the medication to something else, and that's kind of a whole longer question and a little tougher, and often takes a little expertise with an RLS, at least a reasonably well educated RLS doctor.
I have a question that came in from Let's Live. Once you have augmented on a medication like Requip, for example, in the future, can you ever go back to that drug and get results?
Okay, so there's two short-acting dopamine agonist drugs, and that's Requip and Mirapex that I just mentioned before, ropinirole and pramipexole. And many doctors who aren't that expert in restless legs will say, oh, you know, you've had augmentation, we can take you off for a while and put you back on the same drug, or maybe we'll just change to another one because the augmentation may only occur with one of the drugs. And our rule is if you've had augmentation with one short-acting dopamine agonist, if you restart it or another one, you will almost definitely get it sooner or later, and unfortunately, typically sooner. So it is not recommended to do that. Now, after having said that, I sometimes will use some rotational therapy, or if I have a patient who has to go off, let's say they put on an opioid to get off of the ropinirole or pramipexole, and they've been on it for a while, but they have to go off for some reason, I may put them back on the ropinirole or pramipexole, but only for a week or 2 or 3, typically not a period long enough to start the augmentation process again. So, and again, and mostly that should be done by someone who knows what they're doing and can interact with the patient and be aware if something funny is happening so that they can change back to another therapy. So as far as for long-term, no, it's not something we do. There are some individual situations where some experts can do it quite safely and effectively, however.
Next question, is it bad to take gabapentin indefinitely for RLS?
Gabapentin is a drug that's been around for 25, 30 years. It's very well known. And most of the issues that occur with gabapentin typically occur right away, such as sedation, weight gain, sometimes swelling. And those are things that, you'll know in the first month or two and whether you want to stay on it or not. If these things don't happen, for the most part, this can be an incredibly safe drug to use indefinitely. We use it for epilepsy in much, much higher doses, and it's even used in childhood epilepsy. So we have people who've been on it for, 30, 40 years probably already, without any, maybe not that long. I think the drug's been around for 25, 30 years, but, without any significant problem. The only concern is a small percentage of patients may get depression from that class of drug. So if that occurs, the physician has to know that that's a possibility, and then you might have to make a change or decrease the dose to accommodate that concern if it occurs, and that can occur down the line, although it typically occurs earlier than later.
Okay. I still use my CPAP consistently, but I'm still fatigued and fall asleep during the day. Could the hydrocodone interfere with the CPAP?
Okay, there's a couple of parts to that question that I can answer. So hydro is just a long-acting form of hydrocodone, which is what's in the Norco that was in the previous question, or Vicodin. But the Zohydro made a little more for cancer patients because it's a slow release, usually comes in higher doses. It can be used for restless legs, depending on if you use the lower doses. I don't use it all that much, but I've had a few patients who've tried it and done pretty well. Now, any opioid such as hydrocodone, it typically doesn't worsen obstructive sleep apnea, but it may induce what we call central sleep apnea, which is kind of the brain saying, I'm not going to breathe, rather than having an obstruction in the back of the throat. So it is a possibility, and it could make the person more fatigued, but most of the modern, I should say almost all the modern CPAP devices now have either a chip in them or are wireless. And the benefit of that is every time a patient comes into my office for a CPAP check, they have to bring their chip, or we're plugged in wirelessly so they don't, we can connect. And we download their data, and you can see how much apnea they're having. So if the Zohydro is causing an increase in regular obstructive sleep apnea, which it shouldn't do, but even central sleep apnea, the software in the CPAP device will pick that up, and you can see it right away. So that's a very simple thing. If the Zohydro is interfering with the way CPAP is working and making it not cover all the apnea, or especially central apnea, which often is not that well addressed with ordinary CPAP devices. We have special ones that work better on that. It would be very apparent if you're seeing a good sleep doctor who's checking the chip or the wireless information that's very easily obtainable.
Okay. Can taking methadone cause depression? If so, what antidepressant do you recommend taking for it?
Okay. Unfortunately, any opioid can cause depression. I don't see it, a super lot, but it's not as uncommon as I would like it to be. It, maybe like 5 or 10%, maybe more like 5, but that's still a significant amount of people who get some depression. Typically, if the methadone causes depression, I may switch to a shorter acting medication that may not work quite as well for the restless legs in some of the patients, but there's a good chance it might cause less depression. Now, if I'm stuck, which can happen sometimes, I might add an antidepressant if there's no other alternatives. Unfortunately, almost all the antidepressants worsen restless legs, except Wellbutrin, which is the generic bupropion. That's one that does not bother restless legs and may help the patient. Unfortunately, if patients are also anxious, sometimes the Wellbutrin might cause a little bump in anxiety. So one has to be careful. There's a few other, antidepressants that might help, but most of those are not usually as good and have more side effects and may still interact with restless legs. So this is a tough area.
14 months I've been on opiates since augmenting with pramipexole. Opiates control 90%, but I have anxiety. This is from the opiates.
Okay.
I think we just touched base on that.
Well, we did a little bit. This is more the anxiety issue with opiates.
Mm-hmm.
I don't see anxiety very often. Small percentage, less certainly than the depression part. So and unfortunately, the only way to make sure would be to get off the opiate for a week or two and see if it goes away. And this is, for example, a time where I might put the patient back on pramipexole for a week or two and see what happens to depression to make sure it's the opioid, because it may not be.
Okay. Knowing that opioids help RLS, what are RLS experts doing that can educate the FDA so opioids can be approved for RLS treatment? How can we continue to get opiates for augmentation and RLS with all these strict narcotic rules?
Well, there's a couple things. First of all, your RLS Foundation is working with some groups who are going to help them approach the FDA so that they can better understand how we want to use our opioids for RLS. And in conjunction with the Restless Leg Foundation, 6 of us have just submitted a paper that's been preliminarily accepted with some changes called The Appropriate Use of Opioids for Treating Restless Legs. And that's going to be published hopefully in the next few months in the Mayo Clinic proceedings. So that should go a long way as being the first paper that solely addresses the use of opioids for restless legs and a very credible paper. We know that we're in the middle of a so-called opioid narcotic epidemic, and the governments of states and local governments, everyone, they're trying to clamp down on it. But I think we're going to be doing as good a job as we can to educate physicians, pharmacists, legislators, etc., that restless legs and a whole bunch of other conditions are still very appropriate to prescribe opiates and do it in a proper and controlled fashion.
And also from this committee, Dr. John Winkelman has submitted a proposal to the foundation that was funded to study opioids and RLS patients. So that's your RLS dollars at work for you, as well as this legislative effort that the foundation is working on behalf of the RLS community that Dr. Buckfuhrer mentioned. Another one, the next question is, what is the most effective opioid for RLS?
Now, from my experience and that of most of the other experts, we typically find that methadone is the most effective and often the most tolerated opioid for restless legs. I would say about 60% or more of my patients do best with the methadone. uh, we have some theoretical ideas why, of its chemistry and everything, but really we're not sure exactly why. One of the things I like about it, it has a longer duration. It'll often last 8, 9, 10 hours, so you don't have to take multiple doses of shorter acting medications. But again, in patients who don't do well with methadone, I'll go through a whole gamut of other opioids till I find the right one.
Are there any natural supplements that can help boost dopamine levels? Do you recommend any?
Again, we're not sure how and why dopamine really helps restless legs and then eventually causes augmentation. But as far as natural supplements, there's really none that are available that have ever been studied or known to be helpful, or even I don't even have any anecdotal claims of anything of that nature.
What is the pathophysiology behind applying heat or massage to the calves when RLS is ramping up? They both work for me.
Well, first let me say we're not 100% sure, but what many of us think is that this is kind of a uh, something that um, uses the same kind of nerves that are giving a message to the brain, of RLS. Like for example, uh, uh, if you hit your finger with a hammer, the first thing you do is you start shaking your hand, really hard, and the shaking kind of both uses the same nerves that are bringing the pain fibers, and the brain has to process shaking and pain. And if you shake hard enough, the shaking takes precedence. So if you apply heat or massage, it's doing the same thing. It's a kind of what we call a counter stimulation, and uh, the same nerves are kind of going into the brain and the same near areas. And just like a computer, the brain has to multitask and can't spend as much time processing RLS symptoms as it can the heat or massage symptoms.
Next question, are there any alternative new treatments available for severe RLS if you're unable to take methadone, morphine, or mega doses of vitamins? We also get a lot of questions about magnesium at the foundation, if that is a viable treatment to help curb RLS symptoms.
Okay, the answer to this question is a little more complex, but if someone can't take any of the common opioids, and here it's methadone, morphine, or Vicodin, uh, sometimes what I'll do is I'll keep trying. There's like 6, 7 other opioids, and I will tell you most of the time, just by being stubborn and keeping trying different stuff, I can usually find some opioid. But let's assume they just can't take any opioid, which does happen. Then we'll try to use combinations of the existing drugs, which are the alpha-2 delta drugs like Horizont and uh, gabapentin and Lyrica, and maybe combine them with a long-acting dopamine drug that has a little less concern for augmentation. We'll also check iron levels, and this would be a great patient if they're a little low on iron to hit them with an iron infusion, which may also dramatically help their restless legs.
Speaking of iron infusions, how often do those need to be repeated?
Well, it varies quite a lot. In some of the initial studies, they had to repeat them at intervals of 3 months to 3 years. Now we think that the interval is somewhere around, the average interval is somewhere around a year to maybe 18 months.
Have there been any studies on the use of acupuncture for intractable RLS that does not respond to the usual medicines?
There's only been a couple of studies for acupuncture, and so far all those studies really have not helped, even for patients with mild RLS that don't even need medication. There's, as far as we can tell, there's no benefit.
I've tried a natural approach. How bad should the PLM and RLS symptoms get before I seriously consider medication?
Well, that's a very simple question to answer because we only should go to medication when the RLS becomes significant enough that it's disruptive to one's life and annoying enough that you say, hey, it's taking me too long to get to sleep. I'm losing sleep. I'm fatigued, I can't sit and work, I can't do my job, or I can't do things I have to do. When it interferes with your life, that's when you should start considering medication. If you can work around it, you say, well, I have a mild RLS, but if I go to a movie, I can sit at the end and maybe get up and walk a little bit, and it doesn't disrupt the rest of your life. Sure, you can wait for medication, but when it becomes disruptive, you should think about getting some treatment.
What are the non-prescription ways to relieve RLS and PLMS? Are there any over-the-counter drinks or food? Any physical effects from those treatments?
There's not a lot of non-prescription ways. Most of the things that patients do, we've kind of discussed a little bit, is, many patients will do exercises, stretching exercises. They'll use the hot baths, which I'm sure all of you are familiar with. As far as anything food, drinks, there's, some people may find something that helps them, but there's really nothing that can acutely relieve RLS or PLMS symptoms that are over the counter or natural stuff that we like.
What is your experience using medical cannabis for treating RLS?
Okay, let me first say that I have never prescribed it, but here in California, it's very easy to find a doctor who will prescribe cannabis. And of course, recently our state has legalized recreational cannabis. But what I find is that the most effective way, according to my patient anecdotes, is that the marijuana has to be inhaled, because you want to get very, very high levels, which doesn't happen with ingestion or eating it. It usually works with very small amounts of marijuana, like 1, 2, or 3 puffs at the most of a marijuana cigarette. And it typically will kick in about 2 to 10 minutes. However, you get these high levels and the levels will go down. So it probably only lasts maybe 1, 2 hours, possibly 3 at the most. So for someone who has bedtime restless legs and can't take other therapy, and if once they get to sleep, they're good, this might be a reasonable therapy. I've had a few other patients try some of the CBD oil under their tongue and get somewhat similar effects, but I've also had patients tell me that they can ingest enough marijuana to be stoned for 24 hours and have zero effect on their restless legs.
We have a big question on augmentation. It's a multi question. What is augmentation? How does it happen? Is it the same syndrome progressing or worsening, and how is it managed?
Okay, that's obviously a very good question, and I think I described a little bit of what augmentation is. It's a worsening of restless legs from typically taking a dopamine agonist drug that helps initially, but down the road it makes the RLS worse. And what you see typically as the worsening is symptoms occur 2 or more hours earlier. You'll see patients say, oh yeah, I had restless legs at bedtime. I took Mirapex an hour before bed. I was great for 6 months, a year, 6 years or longer. And then now I'm having restless legs at 6 p.m. I never had it before. And it could even occur earlier and earlier. It could go to the other body parts, such as the arms. It becomes more intense. It takes less sitting to make it worse. And the medication doesn't work as well. Now, the big question is, why does this happen? To be honest, we still don't know. We have a lot of controversy here. Our latest theory is that there are 5 dopamine subreceptors, and most of the short-acting dopamine, or most of the dopamine agonists that help restless legs hit the subreceptors 2 and 3 the most, and the least is 1 and 5. And we think this there's some imbalance between the 2 and 3 and the 1 and 5 that starts things going haywire, but how and what, we don't know. Now, the third question here is a very interesting one, because as you may have remembered me saying earlier, many really good or fairly good doctors who take care of restless legs, neurologists or sleep specialists, when they see this worsening occurring over years, they say, this is just natural worsening of the disease, nothing to do with the drug. what I always teach my training doctors in restless legs is that anytime a patient gets worse, if they're on a dopamine drug, it's augmentation until proven otherwise. Now, how do you prove it? Unfortunately, the only way to prove it is to take them off the drug and see what happens. Now, the issue with that is uh, any RLS patient, you take them off the drug, and for about 10 days, the RLS just goes crazy. But if it's an augmentation case, after about 10 days, the RLS will start to get better. And when you're, a few weeks into it, their RLS will be much less and much easier to treat than it was before. Someone who just has natural worsening disease will be just where he was anyway and will need the exact same medication again. So the only way you can tell is by stopping it and seeing if the problems get better over a few weeks. Now, how it's managed, again, that's a whole too long a question to answer here, but there is a free paper you can read and even give to your doctor if you want help.
Right, and we have that at the foundation. If you just email us at info.rls.org, we can get that to you. We have a full complement of materials that we have on augmentation, and also our support group leaders have done a presentation on augmentation that we did in our year of augmentation. So it's something that we hear at the foundation often and can help you with that by providing you with materials that you can take to your provider and start a conversation. Next question, what are the chances of developing augmentation?
Okay, that's a question we can answer a lot better now that we're many years down the road from having used these dopamine agonist drugs. Typically for Requip and Mirapex, which are the short-acting dopamine agonists, what we see is somewhere in the order of 7 to 8% of patients on these drugs each year will develop augmentation to a significant degree. So that means by the time you hit 10 years, 70 to 80% of the patients will develop augmentation.
I also got a question, and I'll just answer. If you email us for that augmentation handout, it also has the dosages, how to manage, how to titrate down if you're augmented. It's a very detailed handout that can be very helpful to someone who needs it to work with a physician in their area. What medication for severe refractory RLS do you recommend when someone is taking a long international flight?
Okay, well, assuming if they have severe refractory RLS, they're probably taking an opioid. And, usually my patients with bad restless legs end up on, let's say, methadone or oxycodone, one of the opioids. But by the time we get them fairly well controlled, they're usually taking only 1 or 2 doses, usually late afternoon maybe, and before bedtime. If they're going to take a flight, especially a long international one, I usually have them take the medication maybe 30 to 60 minutes before getting on the plane. If it makes them sleepy, I make sure they have someone with them who can get them on the plane. I don't want them to fall asleep in the waiting area. And actually, if they're going alone, I'll tell them, you take it as soon as you're in your seat. If the flights, if opioids are not something you can take, then sometimes we can use a dopamine agonist if the patient's not on one. Horizon, the gabapentin-like drugs can be used. They're a little more awkward for that. What I also sometimes will use just on an irregular basis would be the drug Sinemet. That's carbidopa, levodopa. If they're not on a dopamine drug, that sometimes using that just when necessary, such as a flight, may be helpful, but that's a very short-acting drug, so they either need the long-acting form and take it a few times.
Dr. B, we're at the top of the hour. Do you have time to stay online and
Sure.
answer a few more questions?
Sure, no problem.
Thank you. Question, do dopaminergic medications cause mental decline in patients prescribed these drugs?
I don't think they do any such, like as far as a mental decline, like doing damage that will cause people not to think as well. in the long run. But what they can do is they are associated with increased sleepiness. So if someone's taking a drug that can make them sleepy, they might have slower, mental abilities. But if they go off the drug, they should be back to square one.
Okay. What can I do when my doctor is unwilling or unable to treat RLS?
Well, that's a very easy question to answer. Get a new doc, or if or if you like your doctor, just keep seeing him, and go find a separate doctor who can treat your RLS. The only time people are stuck is if they're in a big managed care system like Kaiser. Sometimes it can be more difficult, but even there you can navigate it.
Does RLS indicate, or is it a precursor to Parkinson's disease? And then the second part of the question, is it fairly common to have both Parkinson's and RLS?
Okay, the first part of the question, RLS does not in any shape, manner, or form indicate earlier Parkinson's, and there's no increased incidence of people who have RLS getting Parkinson's disease. As far as the other question, it's a little tricky. If you look at Parkinson patients, they do have a higher incidence of restless leg-like activity. We think restless legs is 10% of the population, the adult population in the United States, and it might go as high as 15 or 20% of Parkinson's. But again, it's sometimes not completely restless legs. It's more some restless leg-like feelings. And the issue is they're given high doses of the dopamine drugs for their Parkinson's, which often will take care of their restless legs anyway.
Okay. How does PLMS differ from PLMD? Is one a nighttime versus daytime problem?
Okay, so this is a matter of definition, first of all. So PLMS stands for periodic limb movements during sleep. And even though 85% of restless leg patients have PLMS while they're asleep, and in fact, restless leg patients also have it when they're awake. But there are more people who have PLMS that don't have restless legs, and the reason for that is there's other conditions such as sleep apnea, narcolepsy, but especially being on an antidepressant like the Prozac family or Effexor, Cymbalta. They can have 40, 50, 60 PLMs per hour while they're asleep. So just having PLMS just means you're kicking when you're asleep, and this is more common in people without restless legs because there's many more people on drugs or have other conditions that may cause these PLMS. So PLMS is only a nighttime condition. The PLMs can also occur again, to answer the second part, in the daytime, but only in restless leg patients. Now, PLMD means that you're having the PLMS bad enough to cause a disorder or disease. We're not sure that really exists. We know people who have lots of PLMs when recorded, both from restless legs or from drugs, and they're not necessarily any worse the next day. So whether it's a real disease or not still remains to be determined. Sometimes restless leg patients will kick so much they can't get back to sleep, but to call it PLMD, they can't have a disorder like restless legs that causes it. So you can't have restless legs and PLMD. You can have restless legs and PLMs. Okay.
Are there any dietary aggravators of RLS, such as salt, sugar, MSG, or food dyes?
Well, as I may have said on our earlier slide, some patients are convinced that gluten or refined carbs, or especially sugar, might provoke their restless legs. Again, I'm not super convinced because it's very sporadic. Strangely enough, the commonest thing that I've heard, especially in my support group, is that ice cream may trigger restless legs. And that's, of all the foods and everything, that's the most common. Of course, I don't know if you can strictly call this a food or something we ingest, but alcohol is probably the most potent and common aggravator of restless legs.
Coffee helps control my RLS. Are you familiar with that, and can you comment on it?
Well, that's interesting because there was an article way back before we even probably had a great definition of RLS, that a study done by one doctor. He presented 25 patients who he cured by getting off coffee. And most of us don't believe that that's really the case. I think that coffee is a stimulant, and anything that stimulates will actually help restless legs. Perhaps when there's a letdown, when the coffee gets out of your system and you get sleepy, you then might have increased restless legs. But for the few hours while the coffee's working, I would bet that most patients will have less restless legs than more.
Here's a question on support groups in the area and how do we get the medical and community involved. So we went ahead and made a slide for everyone. So if you go to our website, go to rls.org, get involved, volunteer, review the requirements, submit a completed application, and you can email Hillary at rls.org to learn more about how to become a support group leader. Questions. I wanted to go through some of the ones that we had submitted from the group. We had two questions about magnesium. So can you discuss that in detail, if it's an effective treatment for RLS and and does it help in any fashion or form?
Okay, I don't think that magnesium really has any effect. I think where the magnesium connection came in was that it's something that's used sometimes with pregnant ladies. And of course, pregnant ladies have, instead of 10% restless legs, up to 30 or more percent of them have it. So there was some connection way back, but again, this has been looked into many times, and we do not think there's a correlation. Still need probably more research on this to really be sure about it. But to what I've seen, I've never seen a patient who's taken enough magnesium to register a difference in their restless leg symptoms.
And I'd also be careful about the amount that you're taking because it has a cathartic effect and you might find you're making frequent trips to the bathroom.
Yes.
So, some other ones. Is there a correlation between varicose veins and RLS?
That came about with an article by Dr. Cantor here in Southern California, probably 20 to 25 years ago. And it's never been reproduced. There's been a couple of articles in something called the Journal of Phlebology, which I never knew existed, but it's a journal that doctors who do varicose vein surgery read. And there was a couple of not so good articles that claim that it helps. I personally think that there's zero correlation between varicose veins and restless legs.
Is RLS a nerve disease, and what exactly causes RLS?
Well, I wish I could answer that. If I could answer that question, what causes restless legs, I guess I'd be a lot more famous than I am now. but no one can answer that so far. But we know it's a neurologic sensory motor disorder. And to give you an idea of one of the things that really nails this down, that it comes from the brain, is that patients have even been known to have restless leg symptoms in a phantom limb, meaning a limb that's not there anymore.
Mm-hmm. Are there any clinical trials to address RLS treatment?
Well, there's still all kinds of trials going on for both devices and I don't. There's not too many going on right now with drugs, but there's always trials, preliminary stuff being looked at. Although we haven't seen any big pushes these days, at least recently, unless you know something I don't know yet, from the big drug companies.
Okay, I had another question for you. The other thing, sorry, just a comment, you can go to clinicaltrials.gov to learn about clinical trials you can participate in, as well as on our website, there's a clinical trials tab, and you can see what's available, what's going on as far as clinical trials in RLS. Let me see. One other question we have is about research. Where do you think treatment or a cure will be discovered, and what is your best guess that we should steer research towards?
I personally think that the iron connection may be a very big one because, in about 60% of patients that you give them an iron infusion, their symptoms just get dramatically better. So if we can figure out what's going on there, how we're losing the iron in these patients, where the iron goes, where it's necessary, what pathways, we likely will get a big clue and get a treatment. The other issue may be we know there's some genes linked to restless legs, and if we can figure out what the function of those or the individual function that's wrong with those genes, that might also help us down the road.
This will be our last question, but we also have a lot of questions that we get at the foundation about surgery in RLS, and we received a question tonight about hysterectomy and does it have an impact on RLS?
Okay, there's kind of two answers to that question. In general, having surgery should technically not have anything to make restless legs worse. But what I find is any kind of trauma, stress, especially a major surgery, I find patients who have either major trauma to their back or spine or have spine surgery will often say, "Oh yeah, my restless legs was good until then, and after that I had trouble." And I can't say why. It could be just the stress level or of something major going on. Don't really know, but it's something we see quite often. The other thing I could say with a hysterectomy, if there's ovaries taken out at the same time as the uterus, there could be hormonal changes, which certainly could make a big change in restless leg symptoms.
And also, as an old orthopedic nurse, where I got my career started, is think about you have a lot of immobility post-op. So that's another trigger for RLS. So keep that in mind. And I think it's important to plan with your healthcare provider to make sure you have medications on board and that you also have medications, at least a 3-day supply with you. We have tons of information at the foundation. We've got, a medication card to tell you which meds that Dr. B's worked with us you can take and or not take. We also have a handout that helps you prepare for surgery because sometimes you've got a lot on your plate and it's just nice to have a checklist to kind of help you along. I wanted to also thank you, Dr. B, tonight, and I appreciate your staying over to answer questions, but I wanted to let everyone know that we have our next webinar on Friday, November 17th, titled RLS and Dementia, featuring Dr. Donald Blywise. You can go to our website and register attend. We actually saw him present at the University of Texas at Austin School of Nursing, and he did an excellent job, and I think you'd be thrilled by his presentation too. So Dr. B, I thank you for joining us tonight, and I thank everyone who stayed online as well throughout the presentation to hear Dr. B's answers to all of these great questions. I appreciate you all for working with us on this new format, and I welcome you to join us on November 17th.